Why choose this presentation? How will this information help you in your day-to-day? Many speech pathologists often feel a bit lost and confused, and I think it's from a combination of inadequate education that maybe some of us have experienced in our graduate school programs and afterwards, conflicting research. One researcher says something, and then it's often contradicted only 6 months later. And the overwhelming reality of medical complexity, where we see a patient and we see a very long list, sometimes pages long, of diagnoses, can make us feel a bit overwhelmed or defeated and stuck in our old ways. So it becomes almost too overwhelming to target any one thing because there are so many different risk factors involved. But there's still so much that we can do for this patient population. And I empathize because I go through these feelings as well. And it's challenging, but also incredibly rewarding. There is also a clinical bias towards overemphasizing the importance of aspiration. And for me too, it's something that has been ingrained in us as students. Aspiration is scary, and aspiration leads to pneumonia. But you're going to find in this presentation that I'm going to outline all of the ways that those two things may not be as scary as you think. Aspiration, for one, doesn't always lead to pneumonia, and we're going to determine the times that it might. But dysphagia is just a small piece of the puzzle, and aspiration pneumonia is still an enigma to a lot of us, even myself, after we have done so much research and I've studied it for so long. It has really really tends to confuse us in terms of who might develop pneumonia from an aspiration event and who might be completely fine. So I'm still surprised to this day. But knowing what we know now and knowing the information that I'm going to present in this presentation, I think it can help us change our approach to this or kind of steer away from this clinical bias that we have developed towards overemphasizing aspiration, towards only focusing on dysphagia, and widen our scope, broaden the way that we look at our patients, and look at it from a more holistic approach. And we can do this by making small changes over time. It's not a drastic change in how we look at the patient, but it is a recognition that we as speech pathologists tend to act like hammers and everything is a nail, meaning every time we see a patient, we think dysphagia and we get scared of aspiration and we get scared of aspiration pneumonia. Of course, some concern is warranted. Dysphagia is a serious condition, or it's a serious symptom that can lead to serious conditions, but it also can be managed quite well, especially if we put it into as a small piece of the puzzle and seeing that whole puzzle. So, aspiration and pneumonia. Aspiration does not automatically lead to pneumonia. It's not that simple. And here is a good point in regards to that. 1998, Dr. Langmore's landmark study on the risk factors for aspiration pneumonia, it becomes clear that confirmed aspiration, even on an instrumental study, is not a significant risk factor for aspiration pneumonia by itself. It's enough, I think, to read it one more time. Confirmed aspiration on an instrumental study is not a significant risk factor for aspiration pneumonia by itself. Now, this is something I have to remind myself of every single day. Because going back to us being a hammer and everything being a nail, and as dysphagia specialists, we tend to think everything revolves around dysphagia. But even when we see someone aspirate on an instrumental study, that is one small piece of the puzzle. The bigger puzzle, the bigger picture that we're trying to look at here, the puzzle itself, is the whole patient. What's going on with them? What are the host factors that may make them more or less likely to develop an infection from that aspiration? So while dysphagia can be and is an important factor, this is not to play down the importance of our role in treating and preventing aspiration pneumonia and dysphagia, other dysphagia related conditions. But when we're talking about aspiration pneumonia, it is not a significant independent risk factor. It has to be present with other risk factors in order to cause aspiration pneumonia. Now we're going to get into the risk factors for aspiration pneumonia, those things that we need to look at to determine the likelihood that this patient will develop a pneumonia from their aspiration. So number one, volume and frequency of aspiration. Pretty self-explanatory. How much and how frequently is the patient aspirating? And then microbiologic contents of aspiration. What is in the contents that is being aspirated? And finally, pulmonary clearance and immune response, the host factors. What's going on with the patient that may make them more likely to be unable to clear out or fight off an infection that results from that aspiration? So these are all the risk factors that I talked about in the beginning of the study that was from preliminary research that I've done with Doreen Benson and Bridget Perry on a research study to tell us what the likelihood of a patient is to develop an aspiration pneumonia. So volume and frequency is our first category. How much and how often is this patient aspirating? So what is the risk that we're looking at? Generally speaking, we need to see the full picture. And being able to see the full picture at once in, for example, the slide that I have coming up is going to help us see all of the risk factors together because it can be very overwhelming to look through the chart and see 10, 15 different risk factors and not be able to kind of understand where they fall in the overall picture. Plus, a comprehensive approach managing multiple risk factors together has been shown by the research to provide us with a more accurate interpretation of what the risk is. So, more specifically, and looking at the big picture and looking at all of the risks, no matter how many there are, provides us with a much more detailed explanation of what's going on with the patient and what that risk is versus pinpointing and singling out any one single risk. And so this is a chart that has helped me tremendously in being able to see, understand, and manage all risk factors for aspiration pneumonia. It is based on research on the articles that are listed below, and it provides a relatively comprehensive view of the risk factors for developing aspiration pneumonia. And they're general, many of them. You can certainly use these for your patients and put in more specific details in terms of what the particular condition or risk factor is. For example, cognitive deficits might be a baseline dementia, pulmonary disease could be COPD, so on and so forth, to tell us what's going on with our patient, what can and should be managed, and what are the types of things that we should look at in order to lower the overall risk. And remember, all three of these categories theoretically need to be met in order for an aspiration pneumonia to take place. So we look at these risk factors to determine what we can get the most bang for our buck for. What can we reduce in order to reduce the overall risk profile and allow that patient to eat or drink certain things. And it doesn't have to be just related to dysphagia, right? We broaden our scope, look at the full picture, and talk to the interdisciplinary team to make sure that we are able to manage and how well we're able to manage some of these other risk factors to say improve oral health, get that patient up and moving around, look at their med list and see if their polypharmacy can be reduced somehow. You know, many other ways that we can reduce the overall risk without becoming draconian and to be super strict on dysphagia alone. Okay, another case study. Carol, 67-year-old female, status post dehydration and UTI. We do a clinical swallow evaluation, and we see that she's coughing immediately following thin liquids on 3 out of 12 trials, so a decent amount, but no access to instrumental study. So there's no respiratory compromise, no change in mentation. She's awake, she's alert, she's oriented. And Carol has a strong preference to continue thin liquids as long as she does small sips, stays upright, some other strategies to make sure that she's staying safe while she's drinking. What would you do? Hard to tell, right? It's certainly coughing a bit. We, of course, wish we had an instrumental study to confirm if that coughing meant aspiration, but it's concerning because it's immediately following the trial. But right now, she seems pretty stable. And if we can follow her closely and monitor the signs, maybe this patient can be okay, and continue to educate her on safe strategies so that she can take the thin liquids as safely as possible, given the fairly limited information that we have about her swallow without an instrumental study. All the while, of course, advocating for that instrumental study so that next time we can really get a stronger picture of what we're looking at. Okay, so overall, thick liquids versus thin liquids. Some of the downsides to thick liquids: silent aspiration, pharyngeal residue, inflammation and fibrosis, so a worsening outcome from that aspiration, increased risk of pneumonia, dehydration, UTI, and may decrease the bioavailability of medication and decrease quality of life. On the other side, thin liquids may have an increased risk of aspiration and associated respiratory conditions from that aspiration, depending on the patient's risk, and possible discomfort if coughing increases from that aspiration.